and well, hopefully Ruth and I will be able to monitor the chats. If you want to put them in the chat, or if you put your hand up, we'll monitor that as well, and there'll be a feedback form to complete at the end. But yeah, welcome and thank you to Kate for this session.
Thanks, Francis. So yeah, so just a little bit of a background to the NIPE examination. So it was brought in about 2008 as a way of standardising neonatal screening across the country, and the idea is to get every infant having a thorough and consistent examination, and kind of the benefits being to spot these diseases early on so that they can be treated, and let's say the outcomes can be improved. For the first checks, usually done by us in hospital, so our kind of target is within the first 72 hours of life. If babies are admitted to NICU, then there's some leniency with that, because often they're too sick or too preterm to have their check straight away. And it's usually paediatric doctors, midwives that have done extra training, or nurse practitioners that will complete that first check. And then the second check will be at the 6 to 8 week check by the GP. And that 6 to 8 week check is particularly important. Some conditions won't be apparent at birth, and they might become more noticeable as time goes on or develop as the infant grows. It helps to confirm any abnormalities that were picked up in that first check and to monitor how those are progressing. And it's a really good opportunity to engage with parents and give them the opportunity to voice any concerns that they have. And it's always a bit kind of crazy in those first few hours to days in hospital. We always try to do the first baby check with the mum or the dad present, but often sometimes that's not always the case if mums are too unwell or babies are in the NICU. So the 6 to 8 week check might be the first time that they've had that examination done in front of them. So yeah, opportunity for parents to ask any questions. And the 4 kind of principal target screening areas are the eyes, heart, hips and testes for boys, but obviously includes a full examination of the baby. So today we're just going to cover a few topics, the kind of themes that have come out from the advice and guidance referrals, and a few things that people have requested. So we're going to briefly just look at plagioccephaly and abnormal shaped heads, poor tone and how to assess tone in a baby, a little bit about fontanelles and what to do if they're small or big. We're going to look at red reflexes, and then some birthmarks and which birthmarks might need referrals or not. And if we've got time, just whisk through a few umbilical disorders as well. So I just looked at a study that actually was done in London, where they interviewed some parents that had just been for their newborn baby checks, just to have an idea about what do parents expect from this 6 to 8 week check and what kind of things have they found helpful and not helpful. And the kind of main themes were that, as well as it being an important check for the babies, that parents found it a really important check for them, and that they described as often at a time when they're struggling with sleep, struggling with their emotions, worries about whether they're doing a good job, and that parents presenting their baby to a trusted health professional and being told, you're doing well, you're doing a good job, everything's going fine, is really reassuring. And even really experienced mums voiced that that was a really important part of their baby's journey for them. Parents also commented on that they really liked it when doctors explained what they were doing as they were going, commenting on the fact that things were normal as they went along, rather than just kind of being a bystander watching it all happen. And they actually found that any referrals that they might needed to secondary care, they experienced that as a reassuring thing rather than a source of anxiety, which is quite nice for us to hear as well. So some top tips that I found along the way. So I found it's really useful to be quite systematic. So I tend to do all my baby checks the exact same way each time, so I know that I'm not missing anything, because there's quite a lot to fit in. I found it really helpful to be opportunistic. So for me, I find it helpful to do the heart sounds, look in the eyes and the femorals first, while the baby's quiet and settled. And then I feel like I can do all the other bits and things, even if the baby's a bit unsettled and crying. So before I even undress the baby, I try and get those few things done at the beginning. Obviously, eyes, be opportunistic to when the baby has their eyes open. It's often helpful to be in a really quiet and warm room and somewhere that you can make it a bit darker so the baby will open their eyes and you find that red reflex a bit easier. And then I normally assess undress the baby and assessing their tone and movements as you're handling them. And then I kind of go back up and do a top to toe check, work my way down. And I always do the hips last of all, because I find that that's the thing that will unsettle the baby and make them cry. So just starting, so back at the top, so thinking about assessing the baby's head and skull, and fontanelle is a big part of that. I heard someone describe it as the paediatrician's handshake is feeling the fontanelle, because it's often the first thing we go to do when we assess a baby. There's a lot of information you can gain from it. But the fontanelles to feel in a baby would be the anterior and posterior. And that the anterior fontanelle can really vary in size depending on the baby, and there's a real range. And particularly, it's interesting that darker skin babies tend to have a larger fontanelle. So the kind of average size is around 0.6 to 3.6 centimeters, but darker skin babies can have a normally slightly larger fontanelle. And then the time at which this closes also differs from baby to baby. The average age of closure is about 14 months, but 1% of babies close by 3 months, and most babies, so almost 100%, are closed by 24 months. But you'd expect, well, it should be open at the 6 to 8 week check, and if it wasn't, that would be an abnormal finding. But the posterior fontanelle, so that's a much smaller fontanelle at the back of the head, that expects to close at about 6 to 12 weeks time, so you might not expect to feel that one. So important to assess the size and the quality of the fontanelle. And that's best done with the infant being calm and supine. So you want it to be soft and flat. It can be, if the baby's kind of upset and crying and straining, it can cause it to be slightly bulged. So that's why you want to make sure you're assessing it when the infant's calm. And then important to assess this in conjunction with the head circumference as well, and to feel along the sutures and make sure there's no gapping and there's no ridging of the sutures as well. So what to think about if you think you've got a slightly small or a large fontanelle. So small fontanelle, so closure of the fontanelle by 6 weeks is pathological, and that should make you think about other things and referring in for that reason. Important to measure the head circumference, so small fontanelles can be linked with microcephaly, and to assess the head shape for any signs of craniosynostosis, and also taking into context of how the baby is. Are they feeding well? Are they handling well? And their general clinical examination. And we'll talk a little bit about how to assess for craniosynostosis on the next slides. With the large fontanelles, there's quite a wide range of different things that can cause this. So again, it's important to take into consideration with the baby's head circumference, how they're developing, and the rest of the examination. But to consider kind of focusing particularly on the skeletal system, looking at any dysmorphic features, any growth issues, assessing their neurological examination and how they're developing, and particularly considering any symptoms such as irritability or vomiting that might make you think this needs to be an urgent referral in. So then thinking about the shape of the head, so I think plagiocephaly is often something that parents are worried about, that they might come to you with concerns about their baby's head shape. Plagiocephaly is really common, especially since the Back to Sleep campaign, which we advise for all parents to reduce their SIDS risk. That does lead to the baby being on their back a lot more, and then this can cause slightly abnormally shaped heads. And I guess the main thing to reassure parents is that it doesn't affect their brain development, and the majority of their cases resolve by themselves once the baby starts moving around and spending less time on their back. But the definition is that it's a deformity of the skull caused by extrinsic forces applying pressure on an intrinsically normal skull. And it's usually in that first few months when the skull's most malleable and when the baby spends most of the time on their back when they're asleep. You're more slightly higher risk of it happening if you've been preterm, if there's been any intrauterine constraints, so particularly in oligohydramnios or multiple birth pregnancies. But the important thing to reassure parents is that it doesn't affect their brain development. And the best way to assess a baby's head shape is as in this picture. So the baby is sat upright on the mum, and then you looking over the top. And what you'd expect with a non-worrying plagiocephaly is a parallel shaped head. So you get a one-sided flattening of the occiput, and you might have a bold spot of hair on this side. And then on the same side, the ear is pushed forward, and you can sometimes get sort of cheekbone prominence on that same side as well. And then the things to talk to parents about. So there's lots of things that the parents can do to help to correct this. So starting to do some tummy time. So this can be started right from when the baby's born. So initially, when they're very little, recommend with the baby on their chest, on their front, and gradually over days you can increase the amount of time that they spend on their tummy. And particularly if parents say, oh, my baby doesn't really like this, then suggesting that they start off with a small amount of time and trying to build up over a few days is a good idea. Trying to avoid the amount of time that they spend in car seats or anything where their head's in a constrained position, and the use of slings and that kind of thing to keep the baby's head off something. You can recommend changing the side of the cot that they put their head, so babies will tend to look out into the room rather than look at a wall, so changing the positioning of their cot can be helpful, and then using toys and shapes for the baby to look at to encourage them to keep turning their head the other way as well. And then things to think about. So you want to make sure that there's no congenital muscular torticollis. And so you'd want to just be assessing the baby's active and passive range of movement on the heads. And if you're worried that there is a something like a sternocleidomastoid tumor or something that's preventing the baby from looking to one way, and that's why they've got a one-sided plagiocephaly, then you can consider referring these babies to the physiotherapist. And then the thing that we don't want to miss is a craniosynostosis, and that would be any sort of odd shape other than the typical flattening of the positional plagiocephaly that we've mentioned. And these are some pictures of some craniosynostosis conditions. So this is where the sutures close early, and this can cause problem with skull and normal brain growth. And it typically involves an early closure of a single suture. And so you'll get different head shapes and different types of craniosynostosis depending on which suture is the one that is fused early. And the most common type of non-syndromic craniosynostosis is the sagittal suture. So that's your top left, so it's your scaphocephaly, and that's your sagittal suture that's closed early, so the suture that runs from the top of the skull right the way to the back. And you often get this really long, narrow head shape that grows forwards and backwards due to restriction growing, and the head can't grow side to side. And the forehead might appear really large, and the sides of the skull are quite narrow. And then the bottom, so this is your unilateral coronal synostosis. So that's one of the sutures that runs from the ear to the top of the head, closing early. And you can see this baby's got quite an asymmetrical forehead and eyebrow, and they've got lack of growth on one side of the head, and that causes quite some flattening. And you can see their eye socket looks different on each side. So on one side it's taller and you get a more open eye, and the bridge of the nose you can see is slightly bent across as well. And then in your top right, so this baby has a brachiocephaly, so both of their coronal sutures at the back from the ears to the top of the skull have fused early, and this prevents normal forward growth of the skull and causes the head to grow out side to side. So this baby's got a disproportionately wide and flat head, and a flat back of the head, and quite a kind of tall extreme height of their forehead, of their incline. So these pictures would all be abnormal and warrant referral, and wouldn't fit with your kind of just normal plagiocephaly pattern. So babies to refer, so if you're worried about torticollis or a sternocleidomastoid tumour, this would be to physio. Any other odd shape apart from that typical occipital flattening with positional plagiocephaly, then to refer to general paediatrics. And if it is typical occipital flattering but quite a severe postural deformity, or there's any problems about developmental delay, then that would be a referral to general paediatrics as well. And there's quite a good referral pathway on Remedy that's got this flow chart and just talks about when to refer and when to monitor the baby in the community. And then the next thing I was just going to talk about was assessing tone in a baby and when to recognise hypotonia compared to normal tone. And I just got some videos to go through that I thought were quite helpful. So I'll just play these through and talk over them. So on the left side, we've got a typical developing baby, and on the right side, an atypical. So on the typical side on the left, you can see the baby is fixing and following with the toy and able to move their head from side to side. And they had good periods where they're able to sustain their head in the midline. They've got lots of anti-gravity movements, and they've got lots of reciprocal kicking of both legs, compared to the baby on the right, who has got quite a lack of anti-gravity movements and spends quite a lot of time still. And you can see they can fix onto the object, but they're not able to track it along to the midline. And then again, so baby on their front, so the typically developing baby, so they've got good tone, they're pushing up with their hips flexed and pushing up onto their knees, they're holding their arms forward, and they're able to keep their head suspended off for long periods of time. Compared to the baby on the right hand side, who's got quite a newborn posture there, and is kind of not able to push their head off, not able to have that power and strength in their arms there. And then next thing would be to assess is the head lag. So the best way to do that, so you can see the lady is holding the baby's arms and pulling upwards. In the typically developing baby, there is some head lag still present, which is normal. But you can see, I'll just flip back. At about 45 degrees, they start to have some good head control themselves. So at the top here, and they're able to keep their head up, hold it up in the midline, compared to the baby on the right, who just has head lag throughout, and then their head flops right forward. And then the last video. So holding the baby in ventral suspension, so you can see the baby on the left has got a nice flat back, and they're able to keep their head lifted up, and their arms and legs are both look like they've got good tone and kicking, compared to the baby on the right, who's got still quite a curved round to their back, heads down, with not much anti-gravity movements of their legs. Just go back to the slides. So important developmental milestones to check at the 6 to 8 week check. So from a gross motor point of view, checking that they've got good head control, that they can raise their head up to 45 degrees when they're prone on their tummy, and that they're able to stabilize their head when sitting in that sitting position. That they're able to track objects and to fix and follow, that they startle to loud noises, and that they have a social smile. And then if you do pick up any hypotonia, there's lots and lots of causes depending on where the lesion is, and that would prompt a referral in to see us. If there's any particular breathing or feeding difficulties, and then to consider a more urgent same-day referral. So next I just thought I'd talk a little bit more about red reflexes. So things I found helpful for checking them. So be opportunistic. So if the baby's got their eyes open when they first come to you, get that done straight away. Make sure you've got a darkened room, that your batteries in your ophthalmoscope are nice and bright. Often sitting the baby up, or the baby sucking on a gloved finger or feeding will make them open their eyes. So there's a few little tricks to try. It's important to go through some screening questions with the family. So any babies where there's a family history of childhood onset eye disorders, so things like congenital cataracts or retinoblastomas, then these babies would routinely be seen by ophthalmology. That should all be picked up on the first baby check, but it's worth checking again. And then for a red reflex to be normal, so they need to be equal in colour, intensity and clarity, with no opacifications or any white spots. And at this point, it's useful to check that the baby is fixing and following as well. And although it's called a red reflex, not all babies will have that bright red appearance. So it tends to be white Caucasian babies where you'll see a reddy orangey reflex. But in Asian babies and black babies, they might have a slightly lighter, so more orangey yellowy colour to their red reflex, and that's completely normal. And in those cases, it's useful that if you can see retinal vessels, you can track them along to the optic disc, and that both reflexes are equal on both sides, and that's reassuring. You can also check parents' reflexes as well, and if they've got a more yellowy red reflex, similar to the baby's, then again, that is reassuring. And then just a question that parents often ask you, what can my baby see at this point? So you can let them know that babies best see from about 8 to 12 inches away. So that's the perfect distance while the parents are holding the baby in their arms, and to encourage lots of face-to-face contact. That's one of the baby's favourite activities. And then so things you want to look out for on the red reflexes. So any pale reflexes that are unequal, that are white, where there's dark spots, then you want to be referring these babies in to see ophthalmology. So one of the things we're looking to pick up is a retinoblastoma. So this is a rare but serious eye cancer, typically affecting children under 5. And this is one of the things that the NIPE is really good at picking up early, so to leading to better outcomes. And usually you'd see a white reflex, as you can see on the babies in these pictures. And then the other thing that we're looking to pick up is any congenital cataracts. And you'd be seeing a clouding or an opacity in the eye that would present as a dull or a white-red reflex. And it can be unilateral or it can be bilateral. And there can be a number of causes, so genetic causes, intrauterine infections, trisomy 21. These babies will already be on a kind of accelerated ophthalmology pathway. And then just a few birthmarks to look at. So lots of normal birthmarks that don't need any referral and just need some reassurance to the parents. So really common are these capillary vascular malformations or salmon patches. And these are often pink, they're flat, they've got quite poorly defined borders. Really common to be on the face, so particularly in between the eyebrows, on the eyelids, and particularly on the nape of the neck, so the classic stalk mark. Birthmark. It's really common. They can change in colour when the baby's crying or when the baby's warm, they can look more red. But just to reassure parents that these are nothing to worry about, that they'll fade by themselves. The ones on the neck tend to persist on, but the salmon patches on the face tend to fade by about 1 to 2 years. Other type of capillary vascular malformations include port wine stains. So these are much less common. These would always be present at birth, and these are larger, flatter, more well-defined, and they're more darker in colour. Most commonly on the face, but they can be anywhere. And they're always flat at birth, but then over time as into adulthood, they can become more bumpy. And some fade, but most remain unchanged, and they grow in size with the child. And then so a few things associated with port wine stains that are important not to miss. So if the capillary malformation is located anywhere on the forehead or the scalp, then that would prompt you to think about Sturge-Weber syndrome. Because in these babies, as well as affecting the skin, the blood vessels over the surface of the brain can also be affected. So this should have been picked up again at the first baby check, but important to check those referrals have all gone through. 75% of these babies with intravascular involvement develop seizures, and they can also have developmental problems later in life. And then the main risk to their ocular health is to glaucoma, so they'll have urgent ophthalmology referrals in place as well. Later in life, the babies that have the intracranial involvement can have a contralateral hemiplegia and some visual field defects as well. And then another association with port wine stains, so commonly on a limb, so an arm or a leg, is part of a syndrome called Klippel-Trenaunay syndrome, and that involves port wine stains, varicose veins, and limb hypertrophy, which you probably won't pick up all those things straight away, and it might just be the port wine stain first of all, but then important to look out for those varicose veins and limb hypertrophy later on in childhood. Infantile hemangiomas, so again, fairly common, and these don't tend to be apparent at birth. So these tend to develop over the first few weeks of life. So this might be a new thing to pick up on the 6 to 8 week check. More common in Caucasian babies and in girls, and more frequent in preterms, babies who have older mothers, multiple births, and low birth weight babies. Most of the time they're on their head and the neck, and most are superficial, and they're due to a proliferation of blood vessels under the surface. And they can be superficial, so these birthmarks tend to be so in the superficial dermis they're quite lobulated and bright red, or they can be deep in the deep dermis and subcutaneous tissue, and they can often have a bluish or a purplish tint to them. And the natural history of these birthmarks is that they have an early proliferation, so they tend to grow really rapidly in the first 3 to 6 months of life, and then they have a plateau phase, and then they start to involute. And 80% achieve their final size by the end of that early proliferation, and the median time is at about 4 months, and most of them have usually grown completely and start to involute at about 12 months, and then over time they'll gradually disappear. I think about 50% are gone by 5 years and 70% by 7 years, and the majority by 10 to 12 years. And the majority of these, if they're kind of small, not in a worrying area, don't need referral in, but babies who definitely need referral. So any birthmarks where there's function threatening, depending on what they're surrounding. So anywhere near the lips, periocular, on the nasal tip, in the genitalia or perineum will need referring in. If they're interfering with feeding at all, if they're in the beard distribution, so these babies have a risk of laryngeal hemangiomas, and on the scalp, because there can be some intracranial associations, or in the lumbosacral with spinal associations. And other reasons why referral might be needed, so there can be complications of bleeding or ulceration with these hemangiomas, and if there's multiple on the body, no matter how big there are, so the kind of cutoff is 5 or more, then babies would need referral because there's potential for visceral involvement as well. And then umbilical disorders, so just got a few slides to go through. So umbilical hernia is really common, especially in preterm babies, low birth weight babies, trisomy 21 babies, or babies more of an African descent. And these need just lots of reassurance to the parents. Most close spontaneously by 4 years, and if persisting after this, then that's the time to refer into the surgeons. And they'll be reducible, painless. They can be more prominent when the child cries, and we just need to counsel the parents what to look out for with any incarceration or strangulation, which is extremely rare, but can potentially happen with the umbilical ones. Granulomas, so really common. So this is an overgrowth of tissue during the healing process of the stump, and you'll often see this little pink red lump that can be a bit wet and leaks some fluid and can take quite a while to resolve. It will be important just to counsel parents about the red flags around infection, particularly talking about infection and spreading erythema of the abdominal wall tissue, and that would be a reason to seek medical help. And there's lots of kind of guidelines around on what to recommend to parents with salt measures and hygiene measures, and then potentially cautery if that's not improving. And then you can get this patent urachus as another umbilical disorder. So the urachus can be a remnant that connects the bladder to the umbilicus, which usually closes at birth, but occasionally this can persist and cause a fistula. And the thing that you'd see from that is you can get persistent drainage of the urine from the umbilicus. And these babies would need an ultrasound to confirm this, and then potential referral into paediatric urology. And again, the same sort of safety net advice around infection. And then there's just a few good resources for baby checks and paediatrics in general, just to point you towards. So there's a few kind of modules that you can do looking at the 6 to 8 week check and NIPEs in general. And then websites I've found particularly helpful. So Paediatric Pearls, don't forget the bubbles, and Paediatric Foam have all got loads of really useful information on them. And any questions?
Thank you, Kate. That was excellent. And it looks like Ruth had her hand up first, I think. So do you want to kick off, Ruth?
It was just a small question. It's about the umbilical granulomas. When would you expect them to resolve? So if they're just doing simple hygiene measures and salt treatment, how long can it take and still be normal?
Oh, that's a good question. I guess we don't normally get to that point where they're referred in to see us. I don't know, Frances, if you...
I think they can persist for several weeks, Ruth. I think a lot of historically, like silver nitrate was used in general practice, wasn't it? But I don't know how commonly that's used now, whether you've ever seen it used or...
It's not something I'm familiar with. I only ever suggest hygiene and salt measures and they don't seem to come back. But I think there's just been a couple that I've seen in the past where they've gone on for quite a while. And so I'm not sure what's normal.
Yeah, I think the honest answer is I'm not totally sure if there's a kind of cut-off, but I guess if there's persisting concerns, then perhaps sending some photos. And I think if there's a concern that this might be discharging or a differential diagnosis, then sort of discussion with the surgeons, I think. But yeah, something we can look up.
Thanks.
And then is it Jackie who's next? Is that right? Or have I got, sorry, it's Kate next, sorry.
Oh, Kate next.
Sorry, Kate, then Jackie.
Hi, I was just asking a question about hips. I had a bit of a run of asymmetrical hip creases last year, and I sent them all for ultrasound scan, and they were all fine. And then I did a bit of research into how significant that sign that was, and it sounded like it wasn't a very significant sign, so I'm wondering whether I should still be referring them or not.
I think that still is in our guideline for one of the things to refer them on to. So I think we just still keep following the guideline. I don't know particularly about the association between that isolated sign and any positive findings, but I think I would still carry on referring them in personally.
Can I answer to that one as well? So I did actually discuss with some of the local paediatric team who are updating the guidelines, which I think are going to come out really soon on remedy. But nationally, the guidelines are that you don't refer for that because there's a lack of evidence behind it. But locally, the paediatric team, I'm not sure who exactly, have had a conversation and decided that they do want us to refer them. So the guidelines are going to be updated and on remedy, I think, within the next few weeks. And that will include, yes, to still do ultrasounds if they've got asymmetrical creases.
Okay, thank you.
Thank you. And I think Sarah just put something in the chat about how that was perhaps covered in the MSK session last month, which unfortunately I couldn't join, but sounds like maybe it was, came up there as well. And then Jackie?
Yeah, hi. So I'm an advanced clinical practitioner and I do the 8-week checks as part of my role. And where I am currently, the partner sort of decided that it wasn't necessary to do the weight or head circumference or height of the 8-week babies. I used to do it in a previous role. So is it something that you would say is essential to do at the 8-week check, or is there flexibility on that? So how far should I be pushing with the partners to say, actually, we should be doing that as part of the check?
I personally, I would say that it's an important part of the check. It's taking into the whole account of the whole baby, and I think head circumference and weight are a really important part of that. I suppose if they've had a health visitor appointment the day before and they've had a weight already, then doing another weight in 24 hours later might not be particularly useful. But I don't know that I've seen lots of health visitors routinely measuring head circumferences as well. So I think it's a really good time to document that and get that down. So personally, I would advocate for that.
Yeah, it was always part of my process, and then I started here, and they were like, "Oh no!" And because as an ACP, you're sort of guided by the partners that you work with. It's sort of a bit of an awkward situation, so that's good to know.
I would definitely agree with Kate, and I have seen a baby fairly recently admitted to hospital with really significant weight loss, and I'm sure that you would have picked up that the baby was scrawny without a doubt, but that was only picked up on the 8-week check because somehow they'd kind of missed their midwifery and health visitor appointment. So I would say any review of an infant is an opportunity to weigh them, and I think, as Kate sort of suggested at the beginning, it provides parents with reassurance that the child's thriving as well, which is obviously really important. So yeah, absolutely agree. I think, was it Sarah said something that she's never done a length? I think that's less important, but certainly a weight and ideally a head circumference, but weight would be number one.
That's great. No, that's fine. I'll go find the baby scales.
Brilliant. And then is it Catherine? Catherine, I think is next.
Yeah, thank you. I'm sorry if I missed this at the beginning because I was slightly distracted walking into work. But it slightly links into the question about head circumference as well. And I do it, and I sort of wonder if is there any relationship between what the head circumference is in relation to what their weight is, or is it just if it's an extremely small, if it's like out of the centile range, that there's an issue?
I think if the head is particularly small or particularly big, I think serial measurements are important. So I guess the first head circumference that they've had at birth is somewhat useful, but there might have been still some moulding or something around that time. So I think if you've got a sort of unusually large head or small head that's disproportionate to what the baby's weight is, then I think take the whole kind of picture into account with examination findings, how the baby's doing, feeding, growing, etc. But I think serial measurements to check that is growing appropriately along a centile and not crossing or going down centile would be important to check.
Okay, great, thank you.
Are there any other questions for Kate? Perhaps not. Ruth, did you want to sort of talk about the upcoming sessions?
I will. So I'll just share my screen and put you off a moment. Thanks, Kate. That was a really brilliant presentation. So, I mean, the most important thing really to point out is that we are slightly changing the timing of these sessions because we're aware that an hour is quite hard to fit in the middle of a clinical day. So we're going to condense them down and do them as half an hour. So as of next month, just note in your diary that the session will start at 1 o'clock with the talk going on until 1:30. We will then ask speakers if they can stay on for a little bit afterwards, so another 10 minutes afterwards, so that if people have any questions that they want to ask, you can just choose to stay on a little bit longer and ask questions. And this little bit that we do at the end with letting you know about other events or changes in remedy guidelines or anything else coming up, we'll just send that on as part of the post-event email afterwards. So next month, we've got Lucy Jefferson, who's going to be speaking to us about paediatric allergy at 1 until 1:30, and that's Tuesday the 20th of August. So that's a date to have for your diaries. We've had a little bit of a changeover of admin staff, and so we don't actually have the sign up for that ready just yet, but it will be emailed out to all of you within the next day or two with the slides from this, if Kate is happy for us to share them. And I'm sure you're all aware of this by this point, but on the BNSSG Training Hub website, if you go to resources, as a drop-down tab, there is Child and Young Person Education, and that's where you can find the sign-up links to all of these sessions, the recordings from any previous webinars that you might have missed. There's also a link there that you can see to the BNSSG Peds Pod, so that's our monthly podcast episode, which is myself interviewing some of the expert paediatricians in the area within topics on their fields. And if there's any face-to-face events, then they're there as well. And just to highlight, on the note of Peds Pod, that we've just had an episode released today called Paediatric Myths and Pitfalls, which I must say is a really good episode with David Capehorn, who I'm sure a lot of you know, but he's just tackling lots of the really difficult questions that we have in primary care, how do you investigate lymphadenopathy and when should you investigate, talking about abdominal pain, blood test results in children. So that's a really good one to check out, and I will pop the link for that in the chat in a moment. Thanks very much for joining, everyone. And please do fill in the feedback form, which is in the chat as well before you go. It's really helpful to have the feedback, because it's really helpful for the speakers who volunteered their time to come and do this, and it also helps to guide what the sessions are like and what topics are covered. So we really appreciate it if you could just take a moment or two to do that. Thanks.
Thanks, everyone, and thank you again, Kate, for an excellent session, and
Thank you.
hope to see everyone again soon.